Hi friends. So today I have decided to talk on an important topic, and that is endophthalmitis. The reason why actually I decided to talk about it, the reason is pretty simple. You know that cataract is the most common cause of blindness in India, and that is why we know that cataract surgery is the most common intraocular surgery, and the most severe complication of this cataract surgery is the bacterial endophthalmitis. So I thought, why not talking about and elaborating about this endophthalmitis. So beginning from the definition itself, what is actually endophthalmitis? It is endophthalmitis. That means inflammation of the innermost coats of the eyeball, leaving or sparing the sclera. Now, this is a very important thing where sclera is spared. And when I'm saying sclera is spared, that means it is not involving the extraocular muscles, because you know that the extraocular muscles are inserted over the sclera. So when I say that a sclera is spared, that means the extraocular muscles are not involved. There will be normal ocular movements. There will be no tenderness. Along with this, there will be no limitation of the movements also. Now, if it involves the sclera also, the muscles will also be involved, and therefore there will be limitation of ocular movements, and that condition will be called as panophthalmitis. So that is actually the main difference between the endophthalmitis and the panophthalmitis. Now coming to the causes. Basically speaking, endophthalmitis can be of two types: the infectious and the non-infectious. Now, more common being the infectious, so I'll be talking about infectious first. Now, this infection which is coming, it can be exogenous, like it can be coming from the perforating injuries, corneal perforations, or it can be endogenous, which can come from dental caries, septicemias. Now, this can also come from the secondary infection from the nearby structures, like we have got the corneal ulcers, we can have the orbital cellulitis, but that is quite rare. Now, which bacteria? Because bacteria are the most common cause of infectious endophthalmitis, so I would like to highlight that basically it can be Staph epidermidis, Staph aureus, we have Streptococcus, we have Pneumococcus, we have Pseudomonas, we have Propionibacterium acne. So, and you know that specifically speaking, two are very important when it comes to the cataract surgery. In early onset, we have Staph epidermidis, and in the late onset, we have the Propionibacterium acnes. It can also be caused by the fungus. We can have Aspergillus, we have Fusarium, we have Candida, but that is lesser common than in cases of bacteria. Now, talking about the non-infectious. Outside the non-infectious, we can have a condition called as the toxic anterior segment syndrome. Now, this is a condition where it is post-operative, but it is not due to infection per se. Rather, it is occurring due to the toxic substances which are deposited over the IOLs, over the instruments. It can occur after the trauma also. So, that is a kind of non-infectious endophthalmitis. Now, how will this patient present? I am per se very concerned about a patient who is post-operative, recently had a cataract surgery, and he can have the risk of endophthalmitis 0.1, 0.2 or 0.3. This is the average risk which a patient can have of endophthalmitis after the cataract surgery. And an important thing is that the maximum risk is from the patient's own flora, and that is why previously we even used to do the trimming of eyelashes. So obviously before the cataract surgery, we should be all prepared. We give the systemic antibiotics, the topical antibiotics, even intraoperatively we give antibiotics, postoperatively also we give the antibiotics. But the single step that gives the best prophylaxis against this bacterial endophthalmitis is the single drop of 5% povidone iodine. That has to be instilled 2 to 3 minutes just before the cataract surgery, and I think that is the single best step to prevent the endophthalmitis from the patient's own flora. Okay, now this patient will present with pain, there will be redness, congestion, there will be photophobia, and obviously it's an alarming condition, and patient should be told about the warning symptoms so that he can call the consultant on call, or the JR or nurse, whoever it is. He should immediately inform that I am having these symptoms. Again, I'll tell, there will be pain, there will be redness, there will be diminution of vision. Now, this diminution of vision is very, very important, because this diminution of vision occurs after the initial improvement, if it was after the cataract surgery, because after the cataract surgery, if it was successful, obviously the vision will improve. Now, due to the infection, again there will be diminution of vision. Now, because of the bacterial infection, lot of exudates, and there will be a large hypopion, that is pus in the anterior chamber, and due to lot of exudation, it will give a whitish pupillary reflex. So, leukocoria, it is a very important DD of the leukocoria also. But per se, here when you see a whitish reflex shining through a dilated pupil, that is also called as the amaurotic cat's eye reflex. Okay, now coming to the treatment. Basically, always remember that early diagnosis and management is the key to success. Earlier it is, better it is, because if you have gone late in the management as well as treatment, you have surely lost the battle for sure. So that is very, very important. Now, as soon as you got the patient, you should always assess the visual acuity. That is the first step. So if the visual acuity is at least hand movement close to the face or more than that, then you can go for the vitreous tap, and you can start with the intravitreal antibiotics. Choice, I will tell you after some time. Now, if the patient vision is not even hand movement and it is PL positive just, then you have to go directly with the vitrectomy. And if he is PL negative, then you have to go with the evisceration. The evisceration that we are doing here, that is called as the frill evisceration. That means we leave a frill of the sclera all around the optic nerve. That is called as the frill evisceration. Okay. Now, the initial patient who was having the visual acuity of at least hand movement close to the face, he will be viewed for his vision after 48 hours. Now, if there was an improvement, you can go with it. If there is no improvement, you can even repeat this intravitreal injection and then again assess after 48 hours. Again, if you are not getting any improvement, then you can go with the vitrectomy along with the IV antibiotics. Now, depending upon the choice, what is the choice of intravitreal antibiotics? See, usually the antibiotics that we give in endophthalmitis, we have to start them with all the routes. And the first route should be the intravitreal antibiotics. That is the best route. So, first we do the vitreous tap. That is actually done. And then that is sent for the culture. And then we give the intravitreal antibiotic. Usually we give a coverage of both gram positive and gram negative. And this is given with the help of a tuberculin syringe along with a 30 gauge needle. The combination can be vancomycin, ceftazidime. Combination can be vancomycin, amikacin. Now, amikacin we do prefer over gentamicin, because gentamicin is more maculotoxic. But nevertheless, we should avoid the aminoglycosides, and vancomycin plus ceftazidime is a good one. Then you can also go with the topical antibiotics. Topical antibiotics you have to give very, very frequently, every 30 minutes to 1 hour. Again, you have to give the both coverage. Vancomycin plus cefazolin, vancomycin plus amikacin, you can give this. Then we have to go with the systemic antibiotics. Now, those systemic antibiotics have a limited role, but most of us give us because we don't want to take any chance. Again, a combination of vancomycin plus ceftazidime, vancomycin plus amikacin, you can go with it. Now, also there is a role of steroids. You will say infection and steroids. Yes, steroids also have a role in endophthalmitis. Now, some of the ophthalmic surgeons prefer to give immediately. Some of them say that wait for 24 to 48 hours, let the infection be controlled and then give. Usually we give the dexamethasone topical route, then we also give the oral route, we also give the intravitreal route. So that is again having a crucial role, because there is a lot of inflammatory response that you are getting in endophthalmitis, and if there is no response in about 48 hours or 72 hours, we go with the vitrectomy. Vitrectomy will be done from the pars plana route, and that is again an important step, because lot of exudates that have been accumulated in the vitreous cavity needs to be removed. And finally, if nothing is helping, then you have to go with the evisceration, and that evisceration is called as the frill evisceration. Endophthalmitis is again a very important indication for the evisceration. Even if it is going into the panophthalmitis, the patient will start showing the limitation of ocular movements. There will be tender ocular movements. Now in that case, again you have to do the evisceration. Enucleation is strictly contraindicated in the cases of the panophthalmitis, because there will be a risk of the spread of infection. So basically, when I am doing the frill evisceration, I want to limit the spread of infection. That is why frill evisceration is considered to be better than the normal one. I hope you must have understood the basic approach actually is very important in the endophthalmitis. And what is the basic difference between the endophthalmitis as well as panophthalmitis? If you like the video, please like and subscribe, and also in the comment section, please give me a feedback what all other topics you want me to discuss. Thank you and good day.